I think in the interest of time, we may need to move on. I'm Dr. Stephen Hodak from NYU Langone Health in New York. I have the pleasure of introducing our next speaker, Dr. Gilles Rousse. Dr. Rousse is from the Unité Thyroid et Tumeurs Endocrines, University Pierre and Marie Curie in Paris. And his topic is the learning curve of thyroid ablative procedures. Gilles.
Thank you, Stephen, for this nice introduction. Good afternoon, everyone. I'm very pleased to be with you. I want to thank Roberto Valcalvi for inviting me and the organizers. So this is our ablation experience at La Pitié-Salpêtrière University Hospital. We started 4 years ago. We have performed 223 ablation procedures since now, 105 with laser, and 118 with radio frequency, and you can see on the diagram that the number increases from year to year. So let us talk first about the learning curve regarding efficacy. Is there something like a learning curve? Sure, there is. On the left part of the slide, you have our experience with laser. On the right part, our experience with radio frequency. On the horizontal axis here, you have the chronological series of patients, and on the vertical axis, the volume reduction at 6 months follow-up. So you see that for both techniques, when we began, we obtained like a little below 50% volume reduction, and as time passes by, we are up to 70%, and I'm not sure the learning curve is finished, so I'll tell you in a few years, probably. I will stress the fact that we do not treat small volumes, 17 milliliters for laser, 20 milliliters for radio frequency, and you can see also that with experience, the volume reduction is in a shorter range, but there are still cases with laser under 50%, while there are none after the 40th procedure with radio frequency. So basically, as this learning curve exists, we have proven it. We really continuously spend time thinking about how to improve and why we improved. So when you look at the figures, still with the laser and radio frequency and the chronological series of patients, one major element is the energy we bring to the nodule, the total deposited energy. And you see that when time goes by with the experience, we deposited more and more energy with laser, more and more energy with radio frequency. And probably there is a close link, an intimate link with the efficacy, with a gain in efficacy. We have shown that this is for real, because when you take on the horizontal axis the deposited energy in joules per milliliter, and on the vertical axis a reduction in percent, you see that with laser, you increase the efficacy up to 70% reduction volume reduction, up to 800 joules per milliliter. And the same phenomenon occurs with radio frequency, with a peak at around 3000 joules per milliliter. So this is very important for practice, because now we aim at delivering at least 600 joules per milliliter with laser, and at least 2000 to 2500 joules per milliliter with radio frequency. So how do you determine that enough energy has been deposited? Of course, you have to control the vascularity in both planes at the end of a procedure. At the end, the nodule has turned hypoechoic with hyperechoic bubbles here, and the vascularity has disappeared. Okay, so that's the least you can do. But is it sufficient? Now let me show you two cases. The first one on the first line. Before treatment, medium central vascularity, practically no vascularity at the end of a session, but at 6 months follow-up, it has reappeared. Whereas the second one has very high vascularity, end of a session no more, 6 months follow-up no more. What's the difference between the two? This nodule has been treated entirely regarding its volume, and the deposited energy is very different. So the vascularity at the end of a procedure is not a sufficient clue to total destruction. But total energy is also not a sufficient indicator. So let me show you this example of a 22 milliliter nodule, which I treated 1.5 years ago. And at the 1 year follow-up, it has reduced at 65%, which is quite nice. This is the destroyed area, and this is the viable area. Now, when you look back at the end of a procedure, it's exactly the same. This is going to turn necrotic, fibrotic, it's destroyed. This will remain viable because it's still isoechoic with no bubble. So here, I undertreated this patient. Regarding the volume, not only the energy, that was good, 2,500 joules, but regarding the entire volume. So why is it difficult to treat the entire volume? Let us talk first about laser. This is an example of a 22 milliliter nodule before treatment. And this is how it looks at 6 months follow-up. You see the destroyed area, the viable area. The reduction is really nice, it's 75%. But with time, this will regrow. There is vascularity, it's isoechoic, it is just a matter of time. So how did we improve? At first, we began with 1 or 2 fibers with the longitudinal approach. I have put here the graph. You have a chronological series of patients and the number of fibers we use. You see that during the 30, 40 to 50 first procedures, we mainly used 1 fiber to 2 fibers. And after that, we switched to 2, 3, even 4 fibers, and we changed our approach to transismic one. And this was really the key to enhance our results. We have proven that because if you take our series of patients and the parameter is the fact that the nodule regrows after treatment, you see that all the nodules that regrew with the red dots are at the beginning below 600 joules per milliliter, and after that, none of the nodules regrew, though probably total energy here is a key, and the number of fibers. Now, what are the technical difficulties with radiofrequency? There are 3 of them. First, huge nodules that extend towards the deep portion of the neck. It will always be difficult to treat nicely and safely this area. Second, seeing the electrode at the beginning of your procedure is very, very easy. But after 5, 10, 15 minutes, it gets very tricky. Where's the tip of the electrode here? Because everything's hyperechoic. And last, when you want to determine if the nodule has been ablated completely, you have to distinguish very subtle differences here from isoechoic to mildly hypoechoic. And this is where the expertise plays a role too. So how did we manage to try treating the entire volume? This is how we proceed. We draw on the skin of a patient the lower pole of a nodule here. Then we draw the upper pole. Then the nodule's half height between the two, and the middle between these 2 points. And we draw the electrode entry line depending on the position of the nodule and the anterior jugular veins. So if you puncture the skin at this point here, middle between upper pole and half height, you will be able to treat all the upper part of a nodule. And then if you puncture it a second time here, you will be able to treat the lower part of a nodule. The penetration angle is very important too. There are two kinds of nodules. The ones that are isthmolobar, like this one, and the ones that are purely intralobar. For this one, what we advise is to enter the nodule with a 30 degrees angle, so it's not very steep, you see yourself very well, and you notice that you will enter the skin at the opposite border of the trachea, here. Then for the intralobar nodule, it's more tricky, because you have to enter the nodule with a much steeper angle. And you will see yourself very less clearly. And of course, you have to enter the skin on the same side of a trachea to achieve that. Stay away, anyway, from the danger zone at all times. So, if you take all these clues, all these techniques, what you will be able to do is to treat the marginal part of a nodule and the deepest part of a nodule. And then you will achieve entire destruction. So what should be obtained at the session's end is this. This is the nodule before the procedure, and on the right part of the slide, this is at the end of the procedure. You see that there are bubbles everywhere at the center, but the marginal part of the nodule here has turned hypoechoic. Now you're sure that you have treated it completely, not only with the vascularity. And this one will really shrink and not regrow. So this is an example of a complete treatment of a 31 milliliter nodule in a single session. It's quite long to treat such a nodule in one session. So first line is the ablation date. Isoechoic, central vascularity, low stiffness. 6 months follow-up on the second line. The nodule has turned hypoechoic here. No more vascularity and diffuse high stiffness. So the message is, not only do you rely on the volume reduction and on the symptoms reduction, but to be sure that your treatment is complete, you rely on 3 parameters: the echogenicity, the vascularity, and stiffness. And there you're sure that this one will never regrow, very, very probably. So beyond efficacy, we're dealing with patients and we have to reduce pain and gain in security. These are our major complications at La Pitié-Salpêtrière in 4 years. We encountered 2 voice pulses, transient ones, of course. 1 with laser, 1 with radiofrequency. 3 nodular ruptures, 1 with laser, 2 with radiofrequency, no other major complications. So how can we avoid these complications? First, you have to choose the right tip. If a nodule is on the isthmus or it's inferior to 3 centimeters, I advise you to take the 7 millimeter tip. If it's over 30 millimeters, 3 centimeters, you can take the 10 millimeter tip. Never the 15. It's very dangerous. Now, considering the length of the shaft of the electrode here, I advise you to take the 7 centimeter long. I have tested the 10 centimeters. What it does, it just bends when you enter the skin. And when it bends, you lose precision. So it's bad. 7 centimeters is perfect. Then you have to avoid pain. And for this, you have to get a good local anesthesia. So 5 millimeters would be of lidocaine, 2% would be for a very small nodule. I usually put 15 to 20. And I make sure that there is a thick layer on it, and I'm targeting the sternothyroid muscle, just this one, close to the thyroid plane. Because if you target just above, it won't work as nicely if you target the sternothyroid muscle. Sometimes it's just a millimeter thick, this muscle, so it can be quite difficult, but you can achieve it. Avoiding hematomas, you have to carefully plan your route, and your major obstacle, of course, is the anterior jugular vein. By turning the patient's head, you can avoid it probably easily. Now, avoiding vocal cord palsy. 2 tricks. During the procedure, because it is under local anesthesia, you can speak, you can talk with a patient, and you have to listen to a voice. If a voice is a little lower, it faints like that, you're not good. You have to stop, probably do the hydrodissection with refrigerated serum, and you also have to take care of where you go. That is to say, here you see your needle when you enter the skin. After that, the bubble diffuses and the heat does so. Now, if you don't respect at least the 7 millimeters space of security here, you will encounter vocal cord palsy, and I advise you not to work at 50 watts in this region. Stay at 30 watts with radio frequency. Now, avoiding nodular rupture. I don't know if you've seen them already, but it looks like that. After 1 or 2 months, the patient calls you, is not happy or she's not happy. He or she has a lump here. It's red, it's painful, and what has happened is the content of a nodule has spread through the muscle plane towards the skin. So, of course, it will heal in 3 or 4 months. It's never a real severe complications. It will heal even spontaneously. But I do not like it, and the patient does not like it either. So how could we avoid nodular rupture? This is an hypothesis. Do not take it for something absolutely sure. My hypothesis is the following. When we move backward with our needle, when we perform radio frequency, and when we approach the nodule's capsule here, we don't see ourselves very easily. You don't really know where the tip of a needle is. And probably, from times to times, we heat and we destroy the nodule's capsule. And then we create a breach. And then when the nodule will liquefy, the liquid goes through the breach. So what I do is I take a safety margin of 3 to 4 millimeters here to be sure I do not burn the capsule. So these are my conclusions. A strict technique needs to be applied to turn ablation into a success regarding efficacy, the total energy, treating margins and deep portion, but also, of course, safety and tolerance, choosing the tip size, the power you use, local anesthesia, a good one, carefully planning the route, listening to the patient, avoiding the danger triangle, and all this takes some time, but I think it's really rewarding in the end. Thank you for your attention.
Thank you, Gilles, for an excellent presentation. I'll remind you, if you have questions, please come up to the microphone and identify yourself. I'd like to ask the first question, Gilles.
Thank you for your presentation. But the questions are the following. I did more or less the same. I used the laser for 10 years and increased the energies, increased the number of sources, up to 4 sources at the same time. And that is very tricky. It's very tricky, it's very difficult. And what about, I would like to have you a comment on charring, because the laser does a lot of charring, and the charring, in my view, is bad, in the sense that after a while, or after 10 years, you will see the charring still there, and the nodule appears like a tumor. So the charring is a bad consequence, and if you have, for instance, radiofrequency ablation after laser ablation, the charring may be an obstacle. And the second comment is on liquefaction. I will show you tomorrow. Hopefully, my voice will be back. Liquefaction, I would advise to have a course of corticosteroids, because cortisone. Because yes, maybe it could be due, liquefaction could be due to a breach you open because you go too close to the capsule of the nodule, but also if you give more energies, as far as you give more energies, you get more granulocytes which make melt, act as melting factor. They release enzymes, lytic enzymes, and the nodule, after a month, exactly as you shown, happens that it melts. So I would advise the corticosteroid course. I would like to have a comment on the charring.
What do you call exactly charring before you leave, Roberto?
Charring is carbonization, carbon debris.
Okay. So regarding the second question, would you say giving steroids at the end of a procedure or for treating the nodular rupture?
Not only, yes, I always give at the end of the procedure corticosteroids, and I give a course of corticosteroids. And when patient complains of swelling, of any pain, then I give more corticosteroids, and I found that this prevents tumor rupture, which is, is not good complication.
Yeah, okay. So we do perfectly agree on the prevention and treatment with steroids of the nodular rupture. Although there is no literature, it's not evidence-based. Expert opinion, but what an expert. And regarding charring, I agree that the pattern is not the same with laser and with radiofrequency. We have much more calcifications with laser than we have with radiofrequency. I don't know if I've encountered any when I'm thinking about it. So the results are not the same. When you want to treat the nodule again with laser, it can be difficult because of the calcifications. If they are small, it's okay. If they are big, it can be difficult. But in both cases, the stiffness increases. With laser and radiofrequency, second treatment can be tricky.
I'm Mohammed Fawzi from Cairo, Egypt. Thank you for the lovely presentation. I want to ask, in order to have a non-ablated area in the thyroid nodule, why not consider using contrast ultrasound before and after during the procedure, like we do in the liver, for example?
Yeah. So the use of contrast ultrasound at the end of a procedure, same thing, is not evidence-based, but I encourage you to try it and to try it in studies so that we can know if it brings some light on the fact that we have completely treated or not. Are we superior to our very, very good Doppler that we have by now? I'm not so sure, but maybe it shows things like interstitial vascularity that we don't see with even our very good Dopplers. Maybe.
Gilles, may I ask a question? You showed that the average volume of the nodules that you're treating with laser was about 17 millimeters, and the nodules that you're treating with radiofrequency ablation are about 20 millimeters. I think those are relatively on the small side. What are the indications that you're using to decide about treating those nodules? And are you finding that for the larger nodules, you're having the same measure of success?
I do understand that 20 milliliters are small nodules, to your mind?
Well, I think in my mind, it's 2 centimeter nodules are often asymptomatic, and they're off.
Not 2 centimeters, 20 milliliters.
20 milliliters.
Yes, because we only speak in milliliters. We do not consider the largest diameter anymore.
Very good.
We only think in volume because it depends on the thickness and on the width. So what we treat really is a volume. Regarding the maximum size, answering your question, the average is like 4.5 centimeters. I've never practically treated nodules that measure 2 centimeters unless they are isthmic and there is a cosmetic concern. That's the only times I've performed it.
Hi, My name is Erivelto Volpe. I'm a neck surgeon from Brazil. I wish to congratulate for a wonderful presentation. I have two little doubts. First of all, I understood that you have available at your service the both methods, radio frequency and laser ablation. And which are the criteria that you use to choose between those two? And the second, you choose in your presentation that you have a complication that you treat with hydrodissection. Yeah. When we perform in Brazil radio frequency, we usually do as a routine hydrodissection. It's the vast majority of our cases, we perform hydrodissection. Why not do you use hydrodissection as a routine? Okay. Thank you very much.
Thank you, and thank you for the two questions. So how do we choose? On the historical basis, we started with laser. And then we switched to radio frequency like a year after that. So by now, we use laser for rather small nodules, the one that can be treated with 1 or 2 fibers, because it's difficult to treat with 3 or 4 fibers like Roberto Valcalvi told you. And if it's of mixed composition, it's better with laser, so and not too much vascularity. So laser is for rather small nodules, mixed composition, low vascularity, all the others, radio frequency. Second question, hydrodissection performs very nicely, but 99% of my patients have a normal voice at the end of the procedure. So I do not feel compelled to perform this hydrodissection. I make them yell, literally yell, and sing, so that I'm sure, not only speak to me, okay, but yell. So I'm sure that the power of the voice is normal. After that, I perform the hydrodissection if they can't yell at me.
Gilles, Maristan, United States. Gilles, a very elegant presentation, and I was looking at the curves that you displayed as to the efficacy improving both energy delivery experience. But at the end of the day, we're looking for relieving symptoms and making the patients feel better. So do you see that there's a continuous slope in that respect? That is, the more you shrink the nodule, the better the symptoms? Or what do you think is the inflection point? Because I'm sure it happens below 100%.
Thank you, Marius, for this question. So, 2 ways of looking at this. Symptoms. If you reduce the volume by 50%, pressure symptoms will disappear. Cosmetic symptoms, it's much more difficult because even if a patient sees a little, it's not cured. So 80 to 85% is the less to make really the nodule disappear. Now, my aim is not only to soothe these symptoms, but it is to prevent regrowth on the long term. I'm competing surgeons, who have proven their efficacy for more than a century by now. So if you tell me in 3 years this nodule will regrow, I'm not happy at all. It will double the cost, it will double the number of complications, so my aim is to destroy them totally. That's why I increased the energy and the volume I'm treating.
So can I clarify, you're saying regrowth is prevented only at 85% cutoff reduction in volume? Or what do you think is the limit at which you prevent regrowth?
I think to prevent regrowth, your aim is to treat 100% of the nodule's volume. Well, I'm exaggerating, of course, but let's say there is 1 milliliter out of 20 remaining, I'm satisfied. There are 5, I'm not satisfied. For sure, it will regrow one day.
Zaina Rohani from Qatar. My question is, we deal with a lot of international patients. So maybe a patient comes to me, had a procedure done in the thyroid, and I'm not aware of what procedure. So ultrasound is going to show hypoechoic with calcifications. What kind of cells do you expect if an FNA is done post-ablative therapy?
Very good question. We're working on that subject. We answer in 4 years, I think. First of all, if it's totally destroyed, no cells. And then if you FNA viable tissue, practically normal cells. Very less deformation or modifications we obtain.
So in between undetermined significant, like follicular lesions, Term of significance is not a possibility.
It is a
post-ablative, or-
possibility. Yeah, we do obtain when nodules regrow and we perform another FNA. From times to times, we have this Bethesda-free lesions of uncertain significance, and then we operate them on.
So that was the next, as in like, if you're uncertain, you go for surgery.
Yes,
After
yes,
that.
yes.
Thank you.
So I do not like to FNA them.
Okay, thank you.
Thank you.